about amlodipine?
It's a calcium channel blocker.
Yep. Okay. So what's the side effects of this? What do we need to look for if our patient's getting amlodipine? What do we need to watch out for? What are some side effects that might cause our patient to not take it, or, besides the hypotension, right? So for all hypertensive medications, we're going to teach them about orthostatic hypotension, right? Make sure you get up slowly until you get acclimated to your medicine, stuff like that. Something that makes amlodipine different than all the other drugs. Specifically for amlodipine, what do we need to teach our patient? A calcium channel blocker, what do we know about those?
It stops calcium from entering the cells of the heart. It's supposed to, it does dilate the arteries. And amlodipine, isn't that one used for the angina with like the chest pain to take? What does it do that make people not want to take it?
Yeah, what's a side effect that might be like, hey, I think we need to switch this to something else? What does smooth muscle relaxation do? What can that cause?
Incontinence?
Opposite.
Constipation?
Yeah.
Okay.
So, right? So if we're having like cramping and constipation, right, our patient's going to be like, I'm not taking this, right? So make sure you educate them on, say, hey, this is, a side effect that may occur if this happens. We want them to tell us. Why do we want them to tell us?
So we could put something else, give them something else?
So we can, get them something else. Exactly. So we can tell the provider, say, hey, this is not working for them. This is why. What else can we do for them? And we'll switch their medications. Does amlodipine or calcium channel blockers affect potassium levels or your kidneys? Anybody remember? Think about it. What y'all think? Oh yeah, that's who we're missing. Wait, y'all, where's Warnika at? I was wondering who we were missing. So what y'all think? Calcium channel blockers? Do they have any effect on potassium? Sorry. What's the name of the drug? Calcium channel blockers. Is it a potassium channel blocker? Calcium. We're not worried. We're not worried about potassium, right? What drugs affect potassium levels? Y'all know this. Diuretics, right? Okay, what about kidneys? Does this calcium channel blocker, are they hard on your kidneys? No. A lot of hypertension medications are actually good for your kidneys. They actually help, right? So we're not going to be worried about any of that stuff. What we're going to be worried about is telling our patient, hey, if you wind up constipated or having abdominal pain, let us know. Don't abruptly stop this drug. If anything, we need to titrate slowly. Why would we need to titrate them off this drug and not stop it abruptly?
It can cause adverse effects.
Mm-hmm. Yeah. So we want to prevent that. Okay. There's quite a few drugs that you don't stop abruptly. If you see that on any drug you're studying, make sure you put that as part of your notes to remember. Okay. Let's see. What and make sure you guys know what drugs, what hypertensive drugs we would be cautious in with the kidneys. Because there is one for sure. There might be more than one, but there is one. I don't know if you guys know, but you do have to be cautious with this drug and the kidneys. Let's see. Okay, so if we have, right-sided heart failure backs up where? If we're having right-sided heart failure, where does it back up? So right side of your heart, if it's failing, right? Where's the blood coming from? It's coming from the body pouring in. So where does right-sided heart failure back up? What is it?
I don't know if I'm right. I'm not right.
What is it? What'd you say?
I don't know if that's right.
I didn't hear what you said.
You said that the right side of the heart, but I was thinking, like, when you were talking about failure, I was thinking the ventricle, but I know, like you said, it backs up, so
right,
it has drop in from the atrium to the right ventricle.
Right and left, right? So right-sided heart, where does the blood for the right side of the heart come from? The lungs or the body?
Body, so it's backing up into the body.
Backs up into the body, systemic. What about the left side? Where's the blood coming from the left side?
Pulmonary,
the lungs, because that's the oxygenated blood, because the left side of the heart pumps the oxygenated blood to the body, right?
Mm-hmm.
So if you have right-sided heart failure, you're getting blood that needs oxygen here, it's going to pump it into the lungs. But if it's failing, it backs up in the body. So when stuff starts backing up in the body, what are things we're going to see? What are some clinical manifestations?
Edema.
Lower extremity edema, bilateral lower extremity edema. What else? You're on mute, Alicia.
I know. I was just trying not to answer.
Okay. All right. So like bilateral low extremity edema, stuff like that. Okay. So that's like one of the major ones. So what about, so this part, so the right side's working and it pumped it into the lungs, but now the left side is failing and it's backing up in the lungs. What are some things we're going to see if it's backing up in the lungs?
Difficulty breathing.
Yes. All right. Okay. So make sure you know signs and symptoms or clinical manifestations, whatever you want to call it, of right-sided heart failure versus left-sided. Is it possible for somebody to be in biventricular failure? Have both sides failing at the same time?
Yes.
Absolutely. So a lot of times if one goes untreated, then the other one starts failing. I mean, because, right? I mean, your body just can't function like that. So things start just really going wrong. Okay, so if we have a patient who has left-sided heart failure, what are some things we think what are some things we would expect this patient to be complaining of?
Cough.
Cough? Why would they be coughing?
Because there's congestion. Pulmonary congestion.
Right, because it's backing up in the lungs, right? So pulmonary congestion. So if you listen to their lungs, what do you think you would hear? What are some things you think you would find?
Like crackles or wheezes.
Mm-hmm. Okay, good. Okay. So how would you explain this to your patient? I say, I don't understand. If I'm having trouble breathing, how does it have anything to do with my heart?
Would it be like it's because you're not getting the, never mind.
Oh, you had it.
Like the oxygenated blood to their heart, or it's getting backed up in the lungs. So it's causing difficulties for them to breathe because the blood is not circulating the way it should be.
Right, it's backing up and it's pushing fluid into your lungs. And so that's how it's affecting you, right? Because you've got all this congestion and those capillaries are starting to leak, right? Because everything's backing up and it's got too much pressure. Okay. Is the person with left-sided heart failure going to be short of breath only when they try to exert themselves? Or is it when they're also at rest? Or what do you think? What is that?
Is it exerting?
So early stages is on exertion, yes. But then when it gets untreated and it's late stages, it's going to be even at rest because it's just getting worse and worse, right? So at first it will just be on exertion, but it will develop into at rest if it doesn't get treated. Okay. Okay. So just make sure you guys know the difference between left and right-sided heart failure, where it's backing up, and what kind of symptoms you would see. Okay. Okay. What else? What is it called when the heart muscle gets thicker?
Sclerosis.
Say that again. I'm sorry, I didn't hear you.
I'm sorry, my daughter keeps talking.
Oh, it's okay.
What? Can you repeat the question?
Oh, so when the heart muscle starts to get thickened, what is that called? What's the term for that?
Is it is that cardiomyopathy or no?
Apathy. Mm-hmm.
Okay.
Hypertrophy, right? Thickened muscles. What are let's see, two major types of heart failure. Let's see. So make sure you guys know what the two major types of heart failure are. Left ventricular function. Let's see. Common type, it's alteration in ventricular contractions. It's called systolic heart failure. Kind of weakened heart muscle. Okay. Second type is diastolic. Okay, so three major types of heart failure. Systolic heart failure and diastolic heart failure. Okay, systolic is weakened heart muscle. Diastolic is stiff and non-compliant.
Can you repeat the diastolic again? It was thickening and...
Yeah, so systolic is weakened And diastolic heart failure is stiff and non-compliant. Just use HF for heart failure. Just less writing. So, okay, hold on. So make sure you know the difference between those two. And which one is thickened? So diastolic. Go ahead. Uh-huh. Yeah. Okay.
I'm sorry. I'm trying to participate and get the information, but my daughter is talking.
That's okay. How old is your daughter?
4.
Oh yeah, mine's 5 now. I know, and she never stops talking or making noise. Sometimes she just makes noise just because it's not even making sense, and she just keeps going.
I'm listening to this conversation. She's in a phase of OMG and all of that. So I'm trying to tell her to go somewhere else and talk.
Well, the more you try to get rid of her, the more she's gonna come back. Yeah, that's what.
Sound like she on the phone with somebody.
She's on FaceTime. She done FaceTime her friend, girl. She in here tripping. And she keeps easing back in here, to sit amongst me and talk.
Let her listen in for a minute. She'll get bored and leave. She'll be like, I'm not trying to hear all that. So I'm leaving. She'll be like, I don't know what y'all talking about. Okay. Okay. What are some signs and symptoms of a patient having congestion, heart congestion?
Chest pain.
Okay. What else? What else would we see? You guys remember from a health assessment?
Shortness of breath.
Yeah, that would be lung congestion, right? What about jugular vein distension? Is that a sign of congestion? Yeah. What about cool or vasoconstricted extremities? What do you think that's related to? Is that congestion or is that something else? I think. Cool or vasoconstricted extremities. What did we just talk about that was on your last test that would make a patient have cool, clammy, vasoconstricted extremities?
The vagus.
What disease process? COPD? Remember that? And why? Do y'all remember why COPDers have cool extremities? Cool, clammy, cool, vasoconstricted?
Is it circulation?
Perfusion.
Perfusion.
Right? You're right, circulation, but think perfusion, right? So if we have cool vasoconstricted extremities, we're going to think that's more of a perfusion issue, not so much congestion. Jugular vein distension is going to be more of a congestion issue, right? What do you think about muscle wasting? Would that be congestion or perfusion?
Perfusion.
Perfusion, right? It's just not, you can't develop the muscles or keep them healthy if there's no perfusion, right? If they're not getting the oxygen they need. Okay. So make sure you study the difference between cardiac, so heart failure, perfusion versus congestion, and how you assess that on your patients. Okay. Let's see. Oh. Okay, left. So if I say left-sided heart failure and left ventricular failure, is that the same thing? Yes, because what's ventricle? Where is that? In the heart. So don't let the words trip you up, okay? So left ventricular failure is left-sided heart failure. It's just in the ventricles, right? So if we have left-sided failure, what kind of clinical manifestations are we going to see? And you guys remember this, we just talked about it. Left-sided heart failure is what? Is what?
The cough.
Yeah.
Oh, are you mean like when you're saying like obstruction is in the lungs?
Lungs. So we're going to hear crackles in the lungs, right? Left ventricular failure, crackles in the lungs.
Difficulty breathing.
Mm-hmm. Yes. And what would be right ventricular failure? Right heart failure, right ventricular failure.
Distended jugular veins.
JVD, right? What else?
Edema.
Where?
In the lower extremities.
Right. Be careful with edema because congestion in your lungs is edema in the lungs, right? So lower extremity edema, or it could be, if it's that bad, it could be in their abdomen, right? So if it goes untreated, the fluid just keeps building. So they could have ascites, JVD, right? Okay, so again, same thing as like the last question that we talked about, left-sided versus right-sided. Just make sure you know the difference between the two, how to differentiate the signs and symptoms, the management of each one. Okay. Okay, what kind of labs would we expect to be ordered for a patient who's in heart failure? What kind of labs would we order? Or expect to be ordered, sorry. What kind of labs would you expect to be ordered for a patient in heart failure?
HBNP?
BNP, yes. BNP. And what is the long name for that?
The natriuretic peptide.
Yeah, make sure you know what it stands for because it's not, they don't use the abbreviation on here for some reason. So make sure you can recognize it without the abbreviation.
Is it HBNP or just BNP?
BNP.
Okay.
Yeah.
For some reason I have H.
BNP. So it's a good diagnostic indicator for heart failure. They use that. That is a very sensitive lab diagnostic for heart failure. Let's see. So electrolytes, BUN, creatinine, liver function test, thyroid, all that stuff, complete CBCs, and all that routine urinalysis. Those are all good tests, right? And important and will be done, but we want to know what is the one that is going to be more specific for heart failure. So make sure you read up on your BNP and heart failure, okay, and how it helps diagnose and manage heart failure. Okay. What is BUN for? What do they use BUN to check out? What's that one specific for? BUN.
Is it creatinine?
BUN and creatinine. What are those?
Is that the kidneys?
Yes, those are common for kidneys. Those are more specific for kidneys, right? Okay. And what's in your CBC? What's a CBC?
Complete blood count.
Yeah, what kind of things do we see in that?
Your red blood cells, your white blood cells indicate, if
So we look for infection. Yeah, look for infection and how your red blood cells are doing, right? If you're anemic, if there's any other thing, anything else going on. Okay. Okay, let's see. Okay, so you're teaching a patient who just got diagnosed with heart failure. What are some things that you would include in your teachings? What are you going to teach a patient with newly diagnosed heart failure?
A healthy heart diet.
Okay. So what kind of lifestyle recommendations are we going to have for this patient? So diet, right? What's the diet for cardiac patients? It was in another question. Y'all remember?
The DASH.
Yeah, DASH. Okay, for cardiac patients, what do we need to restrict in their diet?
Sodium.
Yes, sodium. What kind of things do they need to avoid or cut back on?
Fluid.
Alcohol.
They need to cut back on alcohol. Yes.
Caffeine intake.
Yes.
Red meat.
Yes.
Smoking cessation.
Yes. Yeah, they need to avoid smoke, right? And that includes secondhand smoke, right? What about exercise? Are we going to encourage that? Yeah. And if they're overweight or obese, we're going to try and help them with weight management as well, because that's hard on the heart too. Right?
Uh-huh.
So all these things you're going to be teaching them, right? About increasing exercise, sedentary lifestyle is not so great. We're going to cut back on alcohol. You tell them male is what acceptable per day. How many drinks?
2 drinks.
2, right? Female,
Yep.
1, right? Sodium, we're going to say, okay, you need to decrease your sodium. Try to get it down to what? What's the max amount of sodium they should allow themselves, right?
Mm-hmm.
Okay. Avoid smoking, even if you don't smoke. Like if your partner smokes, maybe have them smoke outside, not in the house. I don't even think some people still do that, but yeah, they need to go outside. Hopefully they'll go outside to smoke. And by making all these lifestyle modifications, they might automatically already start losing weight, right? So, all right, let's see. Okay, what are some things that you would teach your patient to look out for where they would need to call their provider?
A headache that lasts, feeling dizzy.
Mm-hmm. What are early signs of heart failure? Because heart failure patients wind up in the hospital over and over again. So we really want to educate them and help keep them out of the hospital, right? So if we can catch heart failure early, in its early stages, we might be able to keep them out of the hospital. So what are some things that we're going to teach our patient that they can do for themselves at home to look for and monitor for, so that they can call their provider early on rather than later and wind up getting admitted?
Difficulty breathing. That be.
Could be. Is that early or late, you think?
I guess it could be late.
Could be late. I would try and catch it before then. But I mean, they definitely need to report that if that's what's happening. But what about weight? Do you guys remember that in your modules about weighing, having the patient weigh themselves?
Mm-hmm.
So they weigh themselves every day at the same time, hopefully either before they get in the shower or after, because sometimes clothes can change the weight. And what is the weight so what's the weight? If they have more than 5 pounds in a week, weight gain, or more than, 3 pounds in a couple of days, they need to call, because what is that telling you?
Fluid.
Fluid overload.
They're starting to retain fluid. So let's catch this now before it gets worse, right? So weighing a patient, right? That's a big one. Okay, so make sure you know what signs and symptoms to teach the patient to report to their provider about early onset of heart failure, right? Okay. So those are all things you're going to be including in your teachings. Also, like medication compliance, why the medications are important, stuff like that. Okay. All right. All right. So JVD. What do we know about JVD? Jugular vein distension. How do we assess for JVD?
Palpate.
What is it? Sorry.
Palpating the neck.
I couldn't hear you. Something about the neck.
Palpating.
Oh, palpate?
Mm-hmm.
Is that what you said? Okay. How do you assess for JVD? We're not going
That's
to
what she said. Palpate the neck.
We don't need to touch it.
Don't you tell them to like turn their head or something to see if it is like
Right,
extending?
Are they standing up? Do we need to have them lay down? What position do we assess?
Do we have them
45
sitting?
45 degrees. Right? So if it's present at 45 degrees or more, like sitting up, right? Then they have JVD. Okay, so make sure you look up how to assess for JVD and what is the, positive for heart failure. Is the patient laying flat in bed positive for heart failure if they have JVD laying flat?
No.
No, that's not laying flat. It's not going to tell us if they have JVD. Okay. What is jugular vein distension? What is it? Y'all remember? It's the pressure of the heart going against gravity, basically. So try to think about it like that. Pushing, like, right? Okay, so make sure y'all study that JVD stuff, because I see there's quite a few questions about that. All right, let's see. Okay. So left-sided heart failure. Here we go again, left-sided heart failure. What is left-sided heart failure? How do we know if a patient has left-sided heart failure? What's the symptoms they'll have?
Cough.
Crackles in the lung, difficulty breathing.
Mm-hmm. What else? So you said cough, difficulty breathing. So imagine this patient isn't getting any better and they're progressing, they're getting worse. What are you going to see?
They're not getting any worse.
No, if they are getting worse, they're not getting better. They're getting worse.
Is this when dyspnea happens with exertion and rest?
Mm-hmm. So they're starting to get short of breath, even not doing anything. What are some things you think you would need to report to the provider immediately if you saw?
Confusion?
Yeah, like changes in level of consciousness. Yeah, definitely.
Cyanosis?
You're thinking perfusion now. Don't get confused. For cyanosis, they would have to be, like, we're still in the lungs, right?
Oh, okay.
What else could happen that we need to report immediately?
What if we're still in the lungs with like blood in them and their sputum?
Yes. What does that mean?
Like they're coughing up blood, basically, or like,
right.
Yeah.
But what does that mean? What is that a sign of? Do you remember? So not only are they in heart failure now, but they're in acute decompensated heart failure. And that's an emergency situation. Okay. So the dry cough, I mean, that's important to note, but that's not an emergency situation, right? You will probably have complaints of shortness of breath and you're going to hear some crackles and stuff. But when you get to that pink frothy sputum, that's something that needs to be reported right away. And what did we say about the weight gain? How much weight gain? How much weight gain is reportable?
5 pounds a week, or 2 to 3 a day.
Right, or 2 to 3 pounds per day. Yeah, or 5 pounds, more than 5 pounds in a week. All right. Okay. So for a patient who has heart failure, how will we know if the heart failure is getting better? How do we assess to see if our heart failure is getting any better? What are some symptoms of heart failure? Trouble breathing, right? What are some other symptoms? It could be right or left.
Jugular vein distension.
Mm-hmm.
Edema in lower extremities.
Mm-hmm.
Pulmonary obstruction.
Mm-hmm.
Normal heart rate.
Their heart rate may or may not be within range. It just depends on how distressed they are. So what would be some things how we could evaluate if they're getting better?
these things would decrease.
Right.
Or so-
No, right. Exactly. So they would start having, being able to breathe a little better. They might have decreased pain. They might have decreased edema. They might start, if they're holding on to fluid, they'll have increased urinary output. Okay. Let's see. Dumb ass question. Okay, so I feel like this is a trick question. Okay, so overall, you think your patient would feel better? And so, like, say you've been sick for a while and all of a sudden you start feeling better. How are your energy levels? I know, don't ask. That's why I'm going into this much detail with this question, because I think it's dumb. But anyway, it's not for me to.
It's going to go up. Like, they're going to have more energy.
Right. So, yeah, because none of those other things that are reasonable that we discussed are options, but how's your energy level is an option. So, anyway, so we would assess by like, yeah, how's your energy level been? Yeah, feeling better. Okay. We're not going to ask them about exercise because they're probably not exercising yet. They're still in the hospital. How many pillows they use to sleep? I mean, that's significant, but not the best question. Chest pain is a good question to ask, but not the best question when you're trying to evaluate the effectiveness of therapy. So evaluating the effectiveness of therapy apparently is asking the patient about their energy levels, which I have to say, in all my 14 years of nursing, I've never asked a patient about their energy level. So, but whatever. Okay, moving on. All right. Let's see, what's the rationale? They said, I want to see the rationale. The question is open-ended and would provide information about the client's metabolic demands of the body. Chest pain is not associated with heart failure. Asking if the client has been exercising regularly is yes or no question does not provide information about if the client is tolerating exercise, which is what the nurse needs to ask about. Asking about sleep habits would be appropriate because a lot of clients with heart failure will sleep in a recliner with lots of pillows so that they can breathe better. However, this would not be the best question to ask when evaluating the outcome of treatment goals. That's their rationale. So they're trying to see how you tolerate. Okay. All right. Okay, ACE inhibitors. You have a patient who's been prescribed some high blood pressure, hypertension medication. Okay, and you have your patient's like, I'm going to die anyway. I don't see why I should start taking all these medicines. What is the most appropriate way to respond to that patient?
Would it be like therapeutic? Like, why do you feel? I don't know. That might be a totally different subject matter.
Right. Yeah.
Would we want them to elaborate on why, like what Alicia was saying, like why is it that they feel that way? Or
Yeah,
we're like,
we could ask them like, can you tell me more about why you're feeling this way? Or can you tell me more about how you're feeling? And what else?
Would you educate them on, like, I guess, the importance of the medication?
Yeah, we're going to explain to them how this could help delay them, from dying from heart failure, right? Because this is going to help manage that and help, improve quality of life and help them live longer. That makes sense?
Mm-hmm.
Okay. Yeah, so we're just going to encourage them to tell us more about what's going on and try to help educate them on how taking this medicine would benefit them. Okay. All right, so again, ACE inhibitors. What are the two things we look for ACE inhibitors?
Like the side effects,
Mm-hmm.
cough and angioedema.
Right, okay. And so can a patient stop taking an ACE inhibitor abruptly?
No.
No.
Is it safe? No. Okay. What is one circumstance where it can be stopped immediately?
Is it if it causes complications that could be like life or death?
Yeah, and what you just said is a situation that was life or death.
Angioedema.
Right. So that's the only time. Yeah. So if they develop angioedema, yeah, you're done with that drug, right? So that's the exception. Otherwise, you need to slowly come off of it and replace it with something different. Okay, so just make sure y'all study all those different drugs, the ACE inhibitors, the thiazides, all the different diuretics.
Is the pink frothy stuff, did you say that was acute pulmonary edema? What is that right?
Yeah, that's yeah, they're in bad shape then. So it's acute decompensated heart failure.
All right.
Right. Okay. Digoxin. Make sure y'all know about digoxin. That's actually a drug you're going to see a lot of, believe it or not. And it's very important that you guys know about digoxin because it has a very small therapeutic window and it can be very toxic. So that's an important one to know about. So make sure you learn about digoxin. It works really well, but they don't use it until last line because of the toxicity, and it needs to be monitored very closely. Okay, so clinical manifestations of toxicity. So if you have a patient that's on digoxin, you're going to want to make sure you assess for all these things too, right? So anorexia, nausea, visual disturbances, confusion, bradycardia. And what do we do if our patient is symptomatic and possibly having a digoxin toxicity?
Stop
Or
it
if we
immediately.
suspect that. What? Sorry.
We stop it immediately.
I'm sorry, what'd you say?
Stop it, stop the.
Well, we don't want to stop yet, right? What's the first thing? So our patient's telling us this stuff, right? And we're like, okay, first thing is we want to assess. So we're going to get some labs. Okay. So we're going to get some labs and see what the serum digoxin level is. And then we'll go from there. But they may have to hold some doses to get them back down if they are having a true toxicity. Okay. All right, so that would be the first thing you would do. Oh, Lord. Okay. They're big on drugs on this one, y'all. Really big on drugs. Angiotensin receptors. Angiotensin receptor inhibitor. What are those for? Let's see. And look, you gotta remember, you gotta do the generic names. Angiotensin receptor inhibitor. Losartan. Ozar, Benicar, those are trade names. I know losartan, valsartan.
I have them.
So are like the two that we need to know, like, I don't know if this is it for sure, but sacubitril and valsartan.
No, make sure you know the generic. So this, I don't know what this thing has I don't even know why they got it written like that, but taking a prescribed, so angiotensin receptor inhibitor, just know angiotensin receptor inhibitor. And how do you know if it's working? What's it for? So first, what are they for? What do they do? What do the angiotensin receptor inhibitors do, or blockers?
That's the losartan, right? I know that's just for high blood pressure.
Mm-hmm.
I think heart failure.
Yeah. So those are to manage chronic heart failure. So how would we know if they're working? How would we know if this is helping the patient?
Like increase activity tolerance,
Mm-hmm.
increase appetite, vasodilation, improve shortness of breath,
Mm-hmm.
and a decrease in fibrosis over time.
Mm-hmm. Okay.
Yeah.
All right. So make sure y'all know that. What about any nighttime urination? Is there any? Would it increase, decrease? Nocturia?
Decrease.
So it improves a lot of things, right? It helps with decreased shortness of breath, helps increase appetite, helps increase activity tolerance, right? Okay. What can y'all tell me about iron deficiency anemia?
You don't have enough iron in your blood.
Right, iron deficiency anemia, but how does that affect the body? What does the iron do? So on a pathophys level, can you tell me how are we iron deficient? Iron deficient anemia.
Do it carries like hemoglobin and oxygen?
Mm-hmm.
So I guess when you don't have enough, you're not getting enough oxygen around your body.
Mm-hmm. So the hemoglobin is affected. The hematocrit is affected, right? Your H and H. Where is this stemming from? If you're trying to teach your patient of how they're anemic, if they have iron deficiency anemia, how would you explain that to your patient? What's happening in their body to make them anemic?
Can they be losing it somewhere?
Is that iron deficiency anemia?
Oh no.
Right. So that is one type of anemia, but not iron deficiency anemia.
What about the body isn't producing?
Yep, you're close, right? What produces red blood cells?
Is it the bone marrow?
Yep, very good. So the bone marrow is not producing the RBCs like it should, and that's iron deficiency anemia. So if they're bleeding out, that's a different kind, that's a whole nother type of anemia, right? So make sure you know the differences between the different anemias, okay, especially the iron. Okay. Okay. Right. Without the iron, the bone marrow cannot make the RBC, so that's iron deficiency. So the bleeding or destruction of red blood cells, because they also have anemias that are where the body is destroying healthy red blood cells, that's hemolytic. And lytic is what? Lysis, lytic, splitting, right? Destroying heme, blood. Okay. Okay, so your patient that you just explained of how they have iron deficiency anemia. Now you're trying to figure out if their treatment is effective. How would you assess to see if their treatment for their iron deficiency anemia is effective?
Labs. Get blood
Okay.
work.
Yeah. What's the easiest thing first instead of waiting for labs to come back? Yeah, because you would be checking labs often, right? Twice a day, maybe more, maybe less, depending on the provider. But they're probably drawing labs twice a day. What's something you can ask the patient to see? What is a symptom of anemia, iron deficiency anemia? People who are anemic, what do you? Fatigue, right? Cold, fatigue. But fatigue is a huge one. So, we can ask them if they're, feeling better, if they're able to do more, if they're tolerating, getting up out of bed, using the bathroom, right? If they're feeling less tired. That makes sense. So we're going to ask them about their symptoms. And the most common symptom for anemia is fatigue, cold, but mostly fatigue. Okay. What about megaloblastic anemia? Megaloblastic. What's the complaint for megaloblastic anemia?
The vitamin B12.
What's the symptom of that though? Like what would the patient be complaining of?
That be like fatigue also?
Yeah, that's what I was thinking.
No, fatigue is the most common one for iron deficiency.
Okay.
So make sure y'all look up megaloblastic forms of anemia and what are the clinical manifestations of that. Okay.
Mm-hmm.
Is that like, because I'm like reading here the megoblastic, is it like a like skin coloration like jaundice and stuff? Because it's saying like symptoms of anemia may not develop until the anemia is severe, and that's under like megoblastic anemia.
Mm-hmm.
And then it's like in Caucasians, the skin develops a lemon yellow color resulting from all that stuff. Yeah.
I'm in yellow. That sounds great.
I know.
So what site are you on?
On Realize It.
Oh God, okay.
Yeah, and then under like the clinical manifestation, it goes into like the folic acid and then the vitamin B12 deficiencies, because that's like right under the megablastic anemia.
Okay. So megaloblastic, it says lemon yellow. Is that the only thing it says?
And then like under clinical manifestation is like, it talks about like weakness, listlessness, fatigue.
Anything about paresthesia or?
No. Oh, paresthesia and the extremities.
Mm-hmm. Yeah.
They may become confused or difficulty maintaining their balance.
So lemon yellow, neurological symptoms like paresthesia, balance. Okay. Yeah, let me make sure it was in there. Okay. Okay. What kind of patients are at increased risk for developing iron deficiency anemia? What kind of lifestyle would, or what kind of patients are at increased risk for developing anemia, iron deficiency anemia?
Women.
Mm-hmm, women, but what's going on with them? Why did you pick women?
Because if we get cycles.
Say it again. I'm sorry, I couldn't hear you.
Women's menstruation.
Mm-hmm. What kind of menstruation? Would a normal period make every woman anemic?
No, it's the heavier flow, right?
So menorrhagia. They call that menorrhagia. So heavy flow cycles. What else?
Right? Like when you're pregnant, you like the fetus, you have to give a lot to the baby, and I know a lot of people develop anemia throughout pregnancy.
Yeah, you have to take iron supplements, right? So if you had a female who was pregnant but taking her supplements, would she be increased risk for anemia?
Okay, so if she was pregnant and she was taking her prenatals,
is she at risk for anemia or is she increased risk?
That's not true.
Yeah, it's kind of tricky. So she's risk, but she's not increased risk. Now, if she wasn't taking her medicine, she'd be increased risk. Does that make sense?
Okay.
So if we have a female who has menorrhagia and she doesn't eat any meat, especially not red meat, is she increased risk?
And she's not eating the red meat?
Yeah, she's not eating any red meat. And she has really, really heavy periods, like bad menorrhagia.
Yeah.
When she's increased.
Is somebody who eats a high carbohydrate diet, are they at increased risk for anemia? Not really, right? They just said carbs. We don't know what else they're eating. Can't really tell from that. Okay, so that's your distractor. This pregnant woman is your distractor here. So you know how you have two answers that are correct, but you got to pick the best one. So they're trying to trip you up here with that pregnant lady. But she's taking her pills, right? She's taking her pills. So she's at risk. She's just not increased risk. But our little friend with the menorrhagia who don't want to eat meat, she's higher risk.
Okay.
Right? Now, we're going to watch both of them, right? But we're trying to pick who's the highest risk. Does that make sense? So, the client who has history of menorrhagia with a strict vegan diet has highest risk for developing iron deficiency anemia due to blood loss, inadequate dietary intake, foods high in iron. The other clients have a low risk of developing it. How do we reduce her risk? How can we reduce her risk?
Her diet, like if she eat meat.
So we can encourage her, right? But if she's a vegetarian, we might have to just give her supplements. So we need her to take supplements. And then with the menorrhagia, a lot of times birth control can kind of control heavy periods, right? So we might want to recommend, birth control for the reasons specifically for her bleeding to help slow that down. So there are things we can do to reduce her risk, right? Okay. And that. Okay. Okay, pernicious anemia. What's that one? And we kind of somebody said something about that earlier. What's pernicious anemia? What's that one caused by?
When your body can't absorb enough vitamin B12.
That's right. Yeah, so like people with bypass or alcoholics, right? They're not absorbing that B12 that they need, that vitamin B12. Let's see. Okay. Yeah, I think that's what you need to know for that one. All right. What's thalassemia? What's thalassemia, guys?
A blood disorder that causes your body to have less hemoglobin than normal.
Okay. What are the symptoms of thalassemia?
fatigue, weakness, slow growth.
Dizziness.
Okay. What do we need to teach our patients who have been diagnosed with thalassemia?
Do we need to remind them that like their need for medication and not stopping it abruptly?
Okay. So, so we're always going to teach our patients about new medications. What else do we need to teach our patients specifically about thalassemia to keep them out of it? What is it? Sorry.
I was trying to read.
Do they need to know that like there can be neurologic complications?
If what?
Like if they have it for a long time.
But what's something that they can do to help themselves, help prevent like flare-ups or serious complications?
That they may have brittle bones.
Would you teach them about their diet?
Yes. And what else? Why?
Because they can't have too much iron in their diet.
What happens? What happened?
It can too much iron is not good for your heart.
Yeah, that's one thing. Y'all remember what exactly is thalassemia?
A group of hereditary anemias.
What specifically though? What separates thalassemia from the other anemias?
Is characterized by hypochromia.
What does that mean?
An abnormal decrease in the hemoglobin content of the erythrocytes.
Right. So they're not carrying as much oxygen around as somebody without thalassemia. So they're already short on oxygen. Okay, that's thalassemia. That's the kind of anemia it is. Okay. So sometimes they can require blood transfusions, sometimes donor cell transplants, depending on the severity of the disease. Okay. And make sure y'all study about how to prevent complications in patients with thalassemia. Okay. All right, so diet, we know we talked about the iron, but some other things we want to check too. Okay. Your patient's getting a transfusion. They're getting a unit of packed red blood cells. So what are you going to tell your patient? So you're about to infuse this medication. What are some things that you would tell your patient to tell you to make sure that they're tolerating this, or they need to stop it, or if you need to stop it? What is signs and symptoms of a blood transfusion reaction?
What about like shortness of breath or like hives if they start breaking out?
Mm-hmm. When does a reaction usually occur?
Is it within the first 15 minutes?
Yes, within the first 15 minutes, that's when you're going to know that there's a reaction. So we infuse the blood very slowly for the first 15 minutes, and we stand there at the bedside and monitor them for the first 15 minutes. Okay. That's for any blood transfusion. Doesn't matter how many packs of red blood cells they're getting. For each one, you treat it like a new bag, like a totally new transfusion, and you do the same thing for each unit. So for the first 15 minutes, we're going to go infuse it very slowly in case they do have a reaction. And we're going to teach our patient, hey, if you start, getting short of breath or what else, blah, 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 you need to let us know. What are some other things we need to tell them to tell us right away if they start feeling this?
Lower back pain,
Mm-hmm.
fever, chills.
Mm-hmm. 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 All right, make sure you look at blood transfusion reaction, hemolytic reaction, right? All right, but we're all on the right track. What do we do if they start having reaction? Stop it right away.
Stop it.
Yeah, stop it right away. All right, and we have a fresh bag of fluids to flush them out. Okay. Here's another one about transfusion. Let's see. Yeah, red blood cells transfusion. How would we know if our patient is experiencing fluid overload?
Edema or swelling?
Yeah, so edema is a sign of fluid overload. What else?
Weight gain?
We're not going to be weighing them. Like something we can
Oh, sorry.
Okay.
Crackles.
Crackles, shortness of breath, we'd notice first, right? Before we listened.
They'll probably be coughing.
Right, coughing, or they're starting to get short of breath.
JVD.
Uh-huh.
Tachycardia.
What about cognitively?
Confusion?
Mm-hmm. Right. Right. Okay, so know the signs and symptoms of fluid overload versus fluid deficit. Fluid volume overload versus fluid volume deficit. Okay, clinical manifestations of each one. Okay. Make sure y'all know your platelet levels and thrombocytopenia. What is thrombocytopenia?
Low platelet count.
Mm-hmm. So what kind of things do you think you would find on a patient that has thrombocytopenia?
Clotting problems.
What is it? Sorry.
The blood wouldn't clot.
Mm-hmm.
So like excessive menstrual bleeding.
What if it's not time for their cycle? What are some other things you would notice?
Like, well, it says here, like if they're having like surgery or dental work, like excessive bleeding,
Mm-hmm.
or like a nosebleed, or like their gums are bleeding easily.
Okay. Mm-hmm. Yeah. Mm-hmm. Yeah. So think about it like if they're in the hospital bed and you're right. So no signs, clinical manifestations of a patient with thrombocytopenia. Okay. Okay. Secondary immune thrombocytopenia purpura. So ITP. Y'all remember studying that or looking at that? Secondary immune thrombocytopenic purpura. ITP. What are some things? Make sure you know what kind of diseases can cause that.
Is that autoimmune?
Mm-hmm. One of them, yeah.
Viral infections.
Mm-hmm. All right, so secondary immune thrombocytopenic purpura caused by autoimmune diseases. What are some examples of autoimmune diseases?
It says here antiphospholipid antibody syndrome.
That's fun. Okay. What else?
Addison's disease.
Okay. What's something that we can test them for, or we should test them for if they haven't been tested yet? HIV.
HIV.
Viral infections, that's hard, right? Because I mean, there's so many different viruses, right? Drugs, we definitely would screen, go through their drugs, make sure none of their drugs are causing it. We would also screen for hepatitis, right? And any other viruses that we have screenings for. Okay. All right. All right. All right. So here, let's see. Here's another question about that. The ITP, immune thrombocytopenic purpura. So we need to know what to test our patient for, and then also how to manage that patient. How are we going to manage a patient that has this disorder, this autoimmune disorder, which is what now? It's an autoimmune disorder of platelet production, right? So we got autoimmune issues and platelet issues. So if we have platelet issues, what does that put our patient at risk for?
Bleeding.
Bleeding. So what are some things we can teach our patient about to help protect them from having an accident or causing bleeding? This is a tricky one, okay? So this is a lot to this one. So we want to make sure we teach them, like, ways to, just anybody on any kind of blood thinner, same thing, soft toothbrush, brushing your teeth. You want to use an electric razor, not a blade. Don't strain if you're constipated, okay? Rectal injections of medications. Also, there is a very significant importance of explaining to them to avoid taking any kind of sulfur-containing medications. If they're taking them, they should be stopped immediately. Sulfur-containing medications. Make sure y'all look that up, okay? So management, right? What to test for, what are the signs and symptoms, and management, teaching management. Platelet defects. So platelet defects can be caused by diseases, by drugs, medications, right? Over the counter or prescribed. What are some over the counter medications that can cause platelet deficits? What's something that the surgeon would tell you not to take like a week before surgery?
Aspirin
Or NSAIDs, right? No, like ibuprofen, right? So those can cause platelet deficits, even though we don't think about that usually. Let's see. So if we have a patient who's taking NSAIDs and they are admitted with a platelet deficit, we're definitely going to recommend to them, like, maybe, you need to stop taking your aspirin or stop taking your, Motrin, find another way for pain relief, right? And explain to them why. Make sure you know other causes other causes of platelet deficits. Okay, you don't have to get into it, just other causes, like end-stage renal disease can cause platelet issues, right? Because our kidneys actually do a lot more than we think. Okay. Okay. All right. We'll do one more. Thrombocytopenia again. And what's thrombocytopenia? What did we say that was? Right. Okay. So, what drugs are contraindicated in patients with thrombocytopenia? Are there any?
Would that be the NSAIDs and stuff like we were saying?
Yeah, that's definitely one. But is there anything else? Probably not. Like right now, I'm just going to list these in y'all study guide. So make sure you look up each of the drugs. It's this desmopressin, DGAVP, corticosteroids, platelet transfusions, and ramaplastin, plostin. Also, make sure y'all understand when a platelet transfusion is beneficial and when it's not. So, for thrombocytopenia, transfusion is not very useful. Platelet transfusion is not very useful, but also for this ITP also. Yeah, because they're not very effective for those two. So make sure y'all know when platelet transfusions are effective and useful and not effective. Okay. I'll just list those meds on the study guide because that's a tough one. Or I'm sure that Megan will because that's 38. All right, let's just stop there. I know y'all are probably brain dead. Okay. And make sure y'all learn about von Willebrand, just so that doesn't confuse you. Von Willebrand disease.
Okay.
Yeah. They're using some of the stuff from that to try and trip you up on the other questions. You may not see a question specific about that, but some of the options for the answers are von Willebrand. So if you learn about von Willebrand, you'll see it and be like, no, that's for von Willebrand. That's not right. You see what I'm saying? So we're not going to let them trick us.
Oh, that's that bleeding disease where you it's a bleeding disorder.
It's one of them. Yeah. Yeah. All right, guys. So, yeah, I'm gonna try and get the study guide out to you guys by Wednesday. And then Friday we'll meet and make sure y'all take notes for anybody who's not able to be here, just because I know it's last minute, so you can share with them. And we'll finish it because we're almost done. I mean, we're doing pretty good. So we'll definitely finish Friday, which I'm happy about because I wanted to get through this before you guys had your exam. All right. And that's it. Just let me know if y'all need anything before Friday, okay?
You say Friday?
Mm-hmm.
Okay.
Yeah, Friday at 1. All right. All right, guys. I'll see y'all in a couple days. Bye.